الرحيم. اولا بشكر الاستاذ الدكتور لؤي الاحول وكل الاورجنايزنج كوميتي على دعوتي لحضور السيشن دي. Talk about the salvage procedure for treatment of unstable ankle fractures in patients with severe diabetic neuropathy. Diabetic neuropathy characterized by glove and stock peripheral neuropathy with loss of the peripheral reflexes, impaired vibration sense, motor neuropathy, and abnormal ataxic gait. With long-standing cases, there is a combination of sensory-motor neuropathy with autonomic neuroarthropathy and repeated minor trauma result in trabecular microfractures with destructive arthropathy. Stages of Charcot arthropathy, stage 1, characterized by acute inflammatory process with edema, hyperemia, and erythema. Stage 2, characterized by coalescence of new bone at fracture sites and regression of edema, hyperemia, and erythema. And the last stage is the continuation of the consolidation and usually the limb left with disability, either deformity or fixed instability. Marx et al. Recommended addition of stage 0, which represents patient at risk with diabetic mellitus with severe peripheral neuropathy. For simplicity, we can divide it into acute stage and chronic stage. The main difference is in the discrepancy in the temperature between the affected limb and the other limb. Once resolution of hotness start to appear, this means that we start the chronic stage. 4 types of surgery for diabetic foot. In presence of deep infection, usually we do debridement. In recurrent non-infective ulceration in a stable feet, we have to remove the offending agent, which is the bony prominence, and so we do exectectomy. In recurrent ulceration in uncontrollable deformity or instability, we have to do realignment procedure. Of course, in uncontrollable recurrent limb infection, the only option is to do amputation. As regards the ankle fracture in diabetic patient with peripheral neuropathy or in a Charcot joint, complications such as impaired wound healing, infection, malunion, delayed union, and severe Charcot arthropathy are prevalent in this patient population. The problem is that the patient usually has no sense of pain and there is non-compliance with the instructions. So usually the patient walk on one aspect of on one column of the foot. So there will be hazards from impingement on soft tissue with sores, and of course this will they may result in infection, or the osteocartilaginous part, and this can result in Charcot arthropathy. Optimal treatment is controversial. Conservative treatment usually needs long time of immobilization. يعني دايما fractures in diabetic patient usually heal but take longer time, usually double or triple the period that is needed for fractures in non-diabetic patients. Of course, longer immobilization can result in bed-ridden complications and result in osteopenia and affection of the other non-affected contralateral limb. The second option is to do open reduction and internal fixation, but this carry the disadvantage of bulky implant, poor grip and poor purchase in osteoporotic bone with poor soft tissue coverage. And again, this necessitates long immobilization period. The last option is to do primary ankle arthrodesis using different techniques, either plate screws, stable external fixators, and intramedullary nail. This photo shows the failure after internal fixation. This is, of course, because of the poor grip and osteoporotic bone, the poor patient compliance, because the patient has no sensation. So the prerequisites for a technique is a technique to provide rigid fixation, immediate weight bearing, early knee and ankle motion, to be less invasive to protect soft tissue with high union rates and allow stable gait pattern. The intramedullary device is thought to be a good and superior to plates, which is bulky and may impede soft tissue healing. Intramedullary nail can increase stability, correction of ankle alignment, and allowing early wood bearing. As we see in this photo, the nail entered from the calcaneus in a retrograde fashion from the calcaneus to the talus to the tibia, with two holes here in the nail for two locking screws, transverse screws in the proximal part, and two locking screws in the distal part to control the rotational component of the movement. Traditionally, the arthrodesis was done by extensile approach to expose the entire joint to remove part of the bone, either the medial malleus or the lateral malleus, and to use osteotome to remove the articular surface and bone graft to achieve solid fusion. Our protocol is to do the arthrodesis using the transcalcaneal intramedullary nail in a less invasive technique, either by all percutaneous technique or with a limited open technique. Inclusion criteria: age over 40, unstable fracture pattern, marked peripheral neuropathy. The mean follow-up of this study was 18 months. Of course, cases of osteomyelitis should be excluded, and it's important to differentiate osteomyelitis from active Charcot. Initially, X-ray is normal in both situations, but presence of ulcer and sinus discharging pus highly suggestive of osteomyelitis. And MRI, as Professor Dr. Amr al-Badri said, can help in distinguish between the acute osteomyelitis and active Charcot. And another therapeutic test is to elevate the limb. If we elevate the limb for 10 minutes and the symptoms or the signs, the hotness and redness and edema decrease, it is highly suggestive, this is highly suggestive of Charcot. In presence of osteomyelitis, these signs will not disappear by elevation of the limb. The present study, we used a technique of minimally invasive transcalcaneal talotibial fixation in group 1, including 10 patients with all percutaneous technique, and the group 2 with minimally invasive technique through a limited open incision. And we are obligated for that due to presence of previous fixation or due to presence of bony element impingement on the soft tissue or due to fixed deformity to do osteotomy for this deformity. The patient evaluation, both radiologically and clinically, radiologically by for ankle alignment and for fusion and hardware failure, and clinically for deformity and patient satisfaction. Examples of some cases. This is a patient presented with failed osteotensis and malalignment. This is subluxation in the ankle joint, and this is a deformity. We obligated to do a limited open technique here to remove the previous fixation, and this is our procedure through the heel step incision for the entry of the guide wire, which passes from the calcaneus to the talus, then the tibia. Under fluoroscopy, this is the owl in the calcaneus, in the talus, and then in the tibia. And this is the guide wire, and this is the reamer. And finally, this is the intramedullary nail impacted over the guide wire. And this is the two transverse locking screws distally, and there is a two transverse screws proximally. And the foot and ankle is fixed in a position of right angle in 10 degrees of external rotation and 0 to 5 degrees of hind foot valgus. This is the patient pre-operatively and post-operatively with good alignment and stability. This is another case of ankle fracture in a patient with diabetic peripheral neuropathy with best soft tissue around the ankle. Of course, not suitable locally for incision and generally due to uncontrolled diabetes. This is the unstable fracture pattern, severe instability and subluxation. This patient was managed by the all percutaneous technique, additional stab wound from the posterior aspect of the heel through the tendo Achilles, and curette was introduced to remove the articular surface of the tibia and the articular surface of the talus, and we complete the procedure using electrical bear. And this is the patient pre-operatively and post-operatively. This is only the stab incision for the insertion of the nail, and this is the incision, small stab incisions for the locking screws with good alignment and stability in the post-operative and final follow-up radiographs. Another case presented with diabetic Malaysian peripheral neuropathy and wound healing problem, previous wound healing problem with plastic surgery, and presented with this instability, managed by the same procedure. And this is the patient at the follow-up with satisfactory walking with a brace. كل اللي اتعمل بس stab incisions for the locking screws distally and proximally, and the stab incision for the heel. This is an interesting case. This patient was initially managed conservatively in a cast due to apparently benign fracture. The first follow-up X-ray, the fracture in place. Then in the next follow-up, there is deviation of the mechanical axis with dislocation and fragmentation, and the patient developed Charcot arthropathy with severe instability. This is intraoperative C-arm photo showing the dislocation and the severe instability, reduction with guide wire and introduction of the implant. And this is the guide instrument for the intermedullary nail. And this is the completion of the procedure. And this is the stab incisions for the proximal locking screws. This photo shows the preoperative or the patient at presentation and initial presentation. This is the patient after 1 month from the procedure, and the final end result, the patient can walk satisfactorily without brace. Another case with severe instability and Charcot, chronic Charcot, managed by the same procedure. And finally, despite presence of some non-union and pseudoarthrosis in this patient, but she was satisfied and can walk in a brace. Another case with superficial ulcer after exclusion of osteomyelitis. The patient was managed by the same technique with satisfactory result. Post-operatively, the patient was all patients were with bearing for 4 weeks, partial with bearing at the 5th week, full with bearing with comfortable brace after solid fusion with tight control of glucose and reflective biphosphonate. In conclusion, the intramedullary nail with locking screws is generally recommended for unstable ankle fractures in diabetic neuropathic patients, as it can correct angular alignment, increases the stability, allowing early weight bearing, and is a solid method of fixation of tibio-calcaneal instability. In a progressive selected patient, adequate reduction and alignment with satisfactory clinical and radiological results can be achieved by a minimally invasive approach. Thank you.